Assalamu alaikum. It's a long gone. I haven't made any video, but today I would like to discuss about the problem regarding respiratory system. We know that this respiratory system is very high health, and in here there are lots of topics uh, which where I need to be master. Otherwise, I am unable to deal lots of questions. So I would like to talk about this hypercapnia. Auzu billahi minash shaitanir rajim. Bismillahir rahmanir rahim. Rabbi zidni ilma, Rabbi zidni ilma, Rabbi zidni ilma. Hypercapnia. In hypercapnia, the mechanism is there is decreased central respiratory drive. So decreased central respiratory drive, decreased respiratory neuromuscular function, decrease central respiratory drive, decrease respiratory neuromuscular function, decrease thoracic cage or pleural function, airway obstruction, and impaired gas exchange. Decrease central respiratory drive. It may be due to drugs like opioid or benzodiazepine. These can decrease the central respiratory drive. And the next one is CNS trauma, stroke, and encephalitis. So central respiratory drive decrement is due to drugs, due to CNS trauma, stroke, and encephalitis. Second is decreased respiratory neuromuscular function. Decreased respiratory neuromuscular function. The example is SAM, that means spinal cord lesion, ALS, amyotrophic lateral sclerosis, and myasthenia gravis. And decreased thoracic cage or pleural function. It may be due to obesity, hypoventilation syndrome, pneumothorax, rib fracture, flail chest. Decreased thoracic cage or pleural function. These can cause hypercapnia and airway obstruction like obstructive sleep apnea, like COPD. Obstructive sleep apnea is upper airway, COPD is lower airway, and impaired gas exchange. Impaired gas exchange due to cardiogenic pulmonary edema and ILD, interstitial lung disease. So again, I would like to discuss about central respiratory drive decrease. Central respiratory drive, it may be due to drugs, opioid, benzodiazepine, and CNS trauma, stroke, and encephalitis. Decreased respiratory neuromuscular function, it may be due to spinal cord lesion, amyotrophic lateral sclerosis, and myasthenia gravis. Decreased thoracic cage or pleural function is obesity, hyperventilation syndrome, pneumothorax, and refraction of flail chest, airway obstruction, obstructive sleep apnea, and COPD, and impaired gas section, cardiogenic pulmonary edema, and interstitial lung disease. What are the causes of hypoxemia? So first, causes of hypercapnia, then causes of hypoxemia. Cause of hypoxemia, it may be due to reduce PiO2, reduce P inspired oxygen, inspired oxygen, reduced inspired oxygen. It may be, the example is high altitude. In high altitude, there is normally gradient, hypoxia, and hyperventilation. In these two conditions, in hypoxia and hyperventilation, a gradient is normal, and hyperventilation, it may be due to CNS depression, morbid obesity. A gradient is normal, and these two conditions can be corrected by supplemental oxygen. If you give supplemental oxygen, you can correct these two conditions. And the VDL or VDR, that means VQ mismatch, diffusion limitation, and shunting, uh, or right to left shunt, large interpulmonary shunt. So in VQ mismatch, it may be due to small pulmonary embolism, it may be due to lobar pneumonia. In here there is increased A gradient. Diffusion limitation is emphysema and interstitial lung disease. In here there is increased A gradient, and it can be corrected by supplemental oxygen. It can be corrected by supplemental oxygen. And large intrapulmonary shunt. Large intrapulmonary shunt, it may be due to diffuse pulmonary edema. Diffuse pulmonary edema, in here there is increase A gradient. Increase A gradient. Large intrapulmonary shunt. Large intrapulmonary shunt. In here there is increase A gradient, and it cannot be corrected in the shunting and the dead space ventilation. The shunting, the dead space ventilation in these two conditions, large dead space ventilation, massive pulmonary embolism, right to left intracardiac shunting. These can be in this condition there is increase a gradient, and it cannot be corrected by supplemental oxygen caused by localized dead space ventilation or intrapulmonary shunting. So again, I would like to discuss about causes of hypercapnia. Cause of hypercapnia, it may be due to decreased central respiratory drive, decreased respiratory neuromuscular function, thoracic cage or pleural function, airway obstruction, impaired gas exchange. Decreased central respiratory is drugs in CNS. Decreased respiratory neuromuscular function is SAMS, spinal cord lesion, amiable lateral sclerosis, and myasthenia gravis. Decreased thoracic cage or pleural function is obesity hypoventilation syndrome, pneumothorax and rib fracture, or flail chest. Airway obstruction is obstructive sleep apnea and COPD, obstructive sleep apnea and COPD, and finally impaired gas exchange like cardiogenic pulmonary edema and interstitial lung disease. Pneumonia causes hypoxemia. Hypoxemia. Pneumonia causes hypoxemia due to right to left intrapulmonary shunting. Due to right to left intrapulmonary shunting. An extreme form of ventilation perfusion mismatch. An extreme form of ventilation perfusion mismatch depending on how much the lungs are affected by intrapulmonary shunting, and the resulting hypoxemia may be difficult to correct with an increase in the fraction of inspired oxygen. In contrast, hypoxemia due to diffuse pulmonary edema, hypoxemia due to localized interpulmonary shunting, lobar pneumonia, atelectasis, bilateral pulmonary edema typically does not correct with increased FiO2 because the only a portion of the lung is affected, and the normally ventilated alveoli compensated via increased oxygen transfer. In contrast to hypoxemia due to diffuse pulmonary edema, hypoxemia due to localized interpulmonary shunting, lobar pneumonia, atelectasis, basilar pulmonary edema typically does not correct with increased FiO2 because only a portion of the lung is affected. mm, the normally ventilated alveoli compensated via increased oxygen transfer. High altitude illness include fatigue, nausea, headache, lightheadedness, and dyspnea. Fatigue, nausea, headache, lightheadedness, and these symptoms commonly occur within 1 to 2 days of ascent to an elevation of 2500 meter or 8000 feet, 2500 meter and 8000 feet. Mechanism of acetazolamide for prevention and treatment of the high altitude illness. If ambient inspired oxygen is low, peripheral chemoreceptor decrease PaO2. Arterial oxygen is low, increase minute ventilation. Arterial oxygen is low, increase minute ventilation. Increase minute ventilation will increase the arterial oxygen, decrease the carbon dioxide, and hyperventilation causes hyper pH. Hyperventilation causes hyper pH, increase pH. So increase central chemoreceptor pH and ventilation inhibited and PaO2 arterial partial pressure of arterial oxygen, increase arterial oxygen is limited if you use acetazolamide. If you increase acetazolamide, in here acetazolamide accelerated bicarbonate excretion to decrease pH, accelerated bicarbonate excretion to decrease pH, rapidly increase partial pressure of oxygen, PaO2 ceiling, and PaO2 will be improved. If you use acetazolamide, accelerated bicarbonate excretion to decrease pH. And if pH is high, we try to compensate the pH by giving acetazolamide. It will decrease the pH and rapidly increase the partial pressure of oxygen. Partial pressure of arterial oxygen will increase and PaO2 will improve. And in here there is slow bicarbonate excretion and gradually PaO2 ceiling. Acetazolamide helps prevent and treat high altitude illness. Acetazolamide helps prevent and treat high altitude illness and by increasing renal bicarbonate excretion to reduce blood pH and to alleviate central chemoreceptor inhibition of the hypoxic ventilator response. Causes of hemoptysis. Pulmonary causes bronchitis. Bronchiolitis is a condition in the childhood and it is very benign. And in here there is no hemoptysis. But in bronchitis, lung cancer, and bronchiectasis, these three can cause hemoptysis. In cardiac cause, mitral stenosis, acute pulmonary edema can cause hemoptysis. Infectious TB, lung abscess, pneumonia, aspergillosis, these can cause. And hematologic is coagulopathy. And vascular is hematologic is coagulopathy, and the vascular is um, pulmonary embolism and AV aneurysm. Pulmonary embolism and AV aneurysm. And the systemic disease, granulomatosis, polyangiitis, Wood-Pasture syndrome, and the other is trauma and cocaine inhalation. These can cause hemoptysis. So first, lung cause is bronchiectasis, lung cancer. Then cardiac cause Cardiac causes mitral stenosis, pulmonary disease. Then the hematologic causes coagulopathy, and some sort of in lung causes some sort of infection can cause some sort of infection, like TB, lung cancer, like TB, lung cancer, mm, um, aspergillosis, lung abscess, and bacterial pneumonia. And the systemic disease, GPA, galvanosis, polyangiitis, and the good pasture syndrome. Autoantibody against basement membrane. Autoantibody against basement membrane is good pasture syndrome and GPA. Granulomatosis with polyangiitis. In here, Sianca will be positive, and the nose, rhinitis, sinusitis, lung problem, lung infection, and kidney. These trees involve granulomatosis with polyangiitis. And this is a flow chart how will evaluation a case of hemoptysis. Evaluation of hemoptysis history and physical examination to rule out other causes. History and physical examination to rule out other causes. Oropharynx and gastrointestinal. Oropharynx and gastrointestinal. History and physical examination to rule out other causes. Oropharynx and gastrointestinal. Mild or moderate and massive. Mild or moderate and massive. Mild or moderate is chest x-ray, CBC, population study. Chest x-ray, CBC, population study. Renal function and urine analysis, rheumatology, workup if suspected. Mild to moderate chest x-ray, CBC, population study. Renal function, urine analysis, and rheumatology, workup if suspected. If massive hemoptysis is regarded like more than 600 ml of blood through sputum is gone, more than 600 ml per 24 hour or 100 ml per hour, at that moment secure airway, breathing, circulation. If bleeding stops, then do these basics like chest x-ray, CBC, coagulation study, renal function, immune analysis, and rheumatologic workup. If secure airway, if bleeding continues, treat cause persistent bleeding, treated by bronchoscopic intervention and embolization or reset. Treat cause persistent bleeding, treated by bronchoscopic intervention, embolization or resection. CVC, chest x-ray, CVC, coagulation study. If this not happen, then do CT scan with or without bronchoscopy, depending on imaging. In massive hemoptysis, initial management involves establishment of adequate patent airway, maintaining adequate ventilation and gas exchange, and ensuring hemodynamic stability. The patient should be placed with the bleeding lung in the dependent position, lateral position, to avoid blood collection in the area of the opposite lung. Bronchoscopy is the initial procedure of the choice. Bronchoscopy is the initial procedure of the choice as it can localize the bleeding site, provide suctioning and ability to improve visualization, and include other therapeutic intervention like balloon temperature, and electrocuted. Bronchoscopy is the initial procedure. if you find a case with hemoptysis, mild to moderate case, do some investigation why the hemoptysis is happening. If more than 600 ml uh, ml per 24 hours, secure area breathing circulation. If bleeding continues, then bronchoscopic intervention should be done for embolization or resection. Pulmonary arteriography should be performed when there is persistent bleeding and the initial bronchoscopy is unable to localize or secure the airway. Then pulmonary arteriography should be done. It can be precisely identify the bleeding vessel and can be used for therapeutic embolization to stop bleeding. Urgent thoracotomy and surgical intervention. Urgent thoracotomy and the surgical intervention are reserved for patients with unilateral bleeding who continue to bleed despite an initial bronchoscopy and pulmonary artery embolization. Urgent thoracotomy and surgical intervention are reserved for those patients with unilateral bleeding who continue to bleed despite initial bronchoscopy and pulmonary artery embolization. You do bronchoscopy, you fail to stop bleeding, then you do pulmonary arteriography, then you fail to stop bleeding. Do urgent thoracotomy. Fresh frozen plasma should be given in patients with known suspected coagulopathy and are more than 1.5 as the cause of hemoptysis. Cough. The most, the three most important, the three most important cause of chronic cough. Chronic cough lasts more than 8 weeks, and are upper airway cough syndrome, postnatal drip, upper airway cough syndrome, postnatal drip, asthma, GERD. Other causes include ACE inhibitor, airway disease, non-asthmatic eosinophilic bronchitis, chronic bronchitis, bronchiectasis, malic, and pulmonary parenchymal disease. That means lung abscess, interstitial lung disease. Common etiology of chronic cough is upper airway disorder, upper airway cough syndrome, postnasal drips, and chronic sinusitis. Lower airway parenchymal disorder like asthma, post-respiratory tract infection, chronic bronchitis, bronchiectasis, lung cancer, non-asthmatic eosinophilic bronchitis. Other cause of cough is GERD and ACE inhibitor. Upper airway disorder for cough is sinusitis, upper airway and upper airway cough syndrome, post-nasal drip. Lower airway and parenchymal disease. Lower airway and parenchymal disorder is asthma, post-respiratory tract infection, chronic bronchitis, bronchiectasis, lung cancer, and non-asthmatic eosinophilic bronchitis. And the third one is GERD and ACE inhibitor. Evaluation of subacute 3 to 8 weeks or chronic more than 8 weeks of cough. Suspected etiology H and P, suspected etiology and history and presentation. Suspected etiology of the history and the presentation. Evaluate and treat indicated ACE inhibitor, stop ACE inhibitor. Upper airway cough syndrome, first generation H1 blocker, first generation H1 blocker. In upper airway cough syndrome, there is first generation H1 blocker. Asthma, pulmonary function test, asthma pulmonary function test, GRD, empiric PPI, no improvement after intervention. Chest X-ray, no improvement after intervention. Chest X-ray should be done. And if there is a parenchymal disease, purulent sputum or immunocompromised, no specific etiology in that particular cases, you should do chest X-ray. Chest X-ray is indicated in patients without a clear etiology with possible pulmonary parenchymal disease, immunocompromised condition, purulent sputum, and smoking history. In upper airway cough syndrome caused by rhinosinus, including in upper airway cough syndrome caused by rhinovirus, conditions include allergic, perennial, non-allergic vasomotor rhinitis, acute nasopharyngitis, and sinusitis. The diagnosis of airway confirmed by elimination of nasal discharge and cough with H1 receptor antagonist. So upper airway cough syndrome is allergic, perennial, non-allergic vasomotor rhinitis and acute nasopharyngitis and sinusitis. Cough producing cough following a respiratory tract infection due to upper airway cough syndrome or due to effect of the virus. The best approach is to treat empirically with oral first generation antihistamine like chlorpheniramine and combined antihistamine decongestant like brompheniramine and pseudoephedrine. Despite these sedating effects, first generation antihistamine are used and they are very effective. The approach differs from that is very symptoms due to rhinitis and in which intranasal glucocorticoid are the first line. Patients who do not respond to 2 to 3 weeks may require further investigation. Sinus imaging, high resolution CT scan, empiric sequential therapy for GRD, cough variant asthma, chronic sinusitis, non-asthmatic, eosinophilic bronchiolitis. And that's all about. Next, I will talk about the pressure regarding respiratory system. Hope you enjoyed.